This is Dr. Ahmed Al-Mai. I'm a consultant child and adolescent psychiatrist at Aramco John Hopkins Health Center. I'll be talking today about autism, different aspects of autism. This talk will be hosted on the World Autism Day. So I'll be talking about a few things related to autism, updates, some symptoms, and we'll talk about treatment, any updates on treatments. So autism, as you would imagine, takes the attention of many media publications around the world. Time, Newsweek, and many other publications, you will see some articles about autism, about one aspect, about changes, about new treatments. It's no different for local and regional media, which you can see always some articles about autism and what we call now autism spectrum disorder, since the name have changed. This is a study we've done at the Child Adolescent Psychiatric Clinic. We're looking at the different mix of cases that we see. And this was done over 1 month. Now, as you would imagine, the ADHD and behavior problems constitute almost 1/2 or 50% of the cases that we see. Other diagnostic categories that we see with children include things like anxiety, speech and language delays, which we see a lot of here for different reasons. And then there are some other categories of autism. We see about 80% of cases. Now, if we look at the case mix over 1 year, we will see that the ADHD behavioral issues constitute about 43%, and about 13% of the cases that we saw are autism spectrum disorders. Now, language disorders constitute about 14%. A lot of it has to do with a lot of these children who are bilingual, probably taking care of caregivers who speak a different language. All of these play factors in addition to genetics. Other diagnostic categories include mental retardation, or what we call now intellectual disability, in addition to anxiety disorders, which is common in different forms in children. I'll be coming back to talk about some of these diagnostic categories as they occur as what we call associated diagnosis or disorders that we see along with autism spectrum disorder. Now, we want to talk about misinformation, and some of this misinformation that being passed around that autism is caused by vaccines. I mentioned, particularly in 1998, somebody by the name Andrew Wakefield have published an article indicating that vaccines may cause autism. Now, many publications since then have been published to discredit this paper. In fact, vaccines for the most rarely ever been associated with autism spectrum disorder. This study involved only 12 children, and the publication has been withdrawn. But still, some people believe that vaccines have something to do with the etiology of autism spectrum disorders. And I mentioned that because it's becoming very common. In fact, the physician who published this study have lost his license as a result of this false publication, because there was some commercial interest that been cited later on. So there is really no strong evidence to indicate that vaccines are associated with autism spectrum disorder. We see books that have been published that falsely support that theory, but no really scientific evidence have been there to link the two. I'm having trouble with the. Let me just go back here to summarize. I'm sorry, I'm rushing through the slides here. Like I mentioned, currently there's no evidence to support relationship between vaccines and autism. Theories about etiology continue to change, and I'll cover some of the aspects. Okay. There has been research to show there's increased prevalence of autism, diagnosis of autism spectrum disorder. The number of cases have just increased significantly over the last 15 years or so. And there are reasons for that. Some of it is that some of the criteria for diagnosis have changed a little bit, which broadened the age range. This increased public awareness. People are becoming more aware of it. Teachers in particular are becoming more aware of it. Families. There's better case finding, better diagnostic instruments that we have now, and better studies to help with the monitoring and diagnosis. There's no clear incidence that to show that this is increasing. And what I mean by incidence is number of new cases, although diagnostically the numbers are increasing. And I mentioned about the diagnostic criteria in what we call DSM-4 and 5 diagnostic and statistical manual. Okay, genetics, like I said, play a big role in the etiology of autism spectrum disorder. There is no specific genes have been indicated in many cases, although in general, genetic heterogeneity, there's a mix of genes have been indicated. In some cases, like Rett syndrome, chromosome number 5 have been implicated. But in generally, there's a mix of cases as there's not one gene that has been indicated in the majority of cases. We must consider gene interactions. There's something called gene mutations. So they change during pregnancies, or pregnancy, or probably after pregnancy, something that causes these genes to mutate. But there are some genes that have been implicated, as I mentioned, in girls, the Rett syndrome, and there is something called Fragile X, which we see mostly, vast majority in boys. I mentioned Fragile X syndrome. There's some structural, anatomic, genetic changes that take place. There are some theories that suggest environmental toxins, immunological factors, GI, gastrointestinal factors. A lot of this has not been really documented or verified. Autism is summary, it's a multifactorial disease that has a lot of reasons and possible etiologies that contribute to it. There's a lot of studies coming along the way to probably contribute to the etiology and the treatment. Hopefully something will come up with the next 5 years or so. As I mentioned, the autism may not be entirely genetic. There are other factors, environmental and other factors that are contributing to the picture. Epigenetic here, what I mean by epigenetics is there's gene mutations. The genes change over time, probably during pregnancy or shortly after pregnancy. Now, typically we see autism being diagnosed somewhere around 18 to 24 months. Sometimes a bit later, depends on the severity, how soon the child be referred to a specialist for diagnosis, and all of these factors play a role in the diagnosis. Okay. There are some other risk factors like parental age. And strange enough, father's age, older age, is more important as a risk factor as the mother's age. Now, the mother's age is really important in some other disorders like Down syndrome. But in this case, in the autism, father's age has been implicated as a risk factor. Birth complications, children who suffer some brain damage during pregnancy or after birth, difficult birth, preterm birth, they have higher risk for autism than other normal children. Parental exposure to some toxins in the old days, but we don't have the analgesic thalidomide, exposure to dipakine valproic acid, contracting rubella during pregnancy, first trimester, as opposed to third trimester. Some other medications have been implicated, but there is really no solid proof here, like antidepressant SSRI use, especially probably in the first trimester, but really no solid evidence. Potential other risk factors include maternal obesity, diabetes. All of these have not really been proved with solid research. Now, let's talk a little bit about the symptoms. So there are three main symptoms that contribute to the picture or constitute the diagnosis of autism spectrum disorder. One of them is impairment in verbal and nonverbal communication. Okay, a lot of these children have language delay and have delay in social communication, whether it's body gestures, understanding other people's social interactions. That is a problem with most of the autistic children. They have stereotypic behaviors. They might repeat the language. They might have flapping and what we call self-stimulating behaviors. Many of them, they have ritualistic behaviors. They have to follow the same routine every day. And if that changes, that causes them significant anxiety, and they may get into a temper rage. And as I mentioned, the social interaction deficits earlier is the third one. These children have other behavioral, psychiatric, and medical conditions that are very common with autistic spectrum disorders children. One of them is seizures, about 16%. Most recent studies show that about 16% of these children may suffer from seizure disorders. Many of these children suffer from GI problems. At some point, that was implicated that there was increased permeability in the bowels that cause the toxins to go in, get absorbed, go to the brain, and causes autism. There's really no solid evidence for this theory. Many of these autistic children have problems with sleep. They have problems with sensory sensitivity, like what we call sensory integration disorders. So some of them don't feel pain. Like a lot of these autistic children, when they're angry, they're upset, they bite themselves, and they may actually cause some serious damage to, injure themselves, but they don't feel the pain. Some of them are extra sensitive to certain stimuli, certain sounds. And all of this together we call part of sensory integration disorder. They engage in, like I mentioned, self-injurious behavior, and about 1 to 2/3 of these children might have mental retardation, or what we call now intellectual disability. Many of them have issues with their immune system. They might be easier to contract infection. They might show evidence for other immune disorders. Now, I mentioned prevalence earlier, but there is increase in prevalence of autism. For instance, before I completed my training, it was in the late 90s. We used to call it autism, and then what we call now autism spectrum disorder. Okay, non-specific. And it was autism was diagnosed 1 in 1,500. Now we talk more about autism spectrum disorder. We talk about mild, moderate, and severe forms. The CDC, Center for Disease Control in the US in 2002, studies showed that the prevalence was 1 in 150. Children will probably suffer from some form of autistic symptoms. Studies over time have shown increased prevalence due to the factors I mentioned earlier. Most recent study shown by Leventhal and Kim in 2011 showed actually some prevalence rates of 1 to 40. Now that includes all the cases, severe cases, very mild cases that may not be actually diagnosed easily because the symptoms are mild. Just in comparison, we've seen the increase in autism here in red and actually in blue line compared to other disorders like epilepsy and cerebral palsy, and we can see them down here at the bottom. Well, the rate of increase for autism spectrum disorder have gone up significantly here between 1987 and 2007 in one of the studies. As I mentioned earlier, one number is increasing. We said broadening of criteria. We do have now better tools and scales to diagnose it, public awareness. There's more services that children have been referred to, this wider age range, and many other factors. I mentioned some of them earlier. Now, we do have some of the scales, some of them the screening scales, SCQ, social communication, questionnaire. There's SRS and chat, which is very commonly used in primary care physicians and to screen children, and if they pick up any red flags, then they get referred to the specialist. Here, some of the autism symptoms, comparing the highly functioning and low functioning children with autism. So some of the children with severe autism have actually many symptoms. That includes language, poor social skills, and they may have severe other behavioral problems. On the mild end of the spectrum, many of these children may not have problems with language. They have fewer core symptoms of autism, like the flapping, self-stimulating, repetitive behaviors, and speech, and they tend to have better social skills. So one end to the other. In social communication disorder is another disorder. In the old days, we used to call Asperger. Now, these days, Asperger diagnosis has not been proved through many of the late research. So what we have now, what it's called, is these children have possibly delay in social skills. They may have repetitive language, or what we call echolalia, some of the repetitive behaviors, but they don't really have some of the severe symptoms like the flapping, self-stimulating, self-injurious behavior, and of that. But they have severe social delays, and they have good language skills, and they fall into a category of what we call social communication. So they tend to be very high functioning end of the spectrum. We don't call them autistic, but we call them social communication disorder. Earlier research I've done with my research team about 5 years ago. It's really important to do local studies, because when we do that, it gives us an idea about what does these disorders look like locally. Excuse me. And that help us in initial screening, diagnosis, and later on providing treatments for these children. So we screened about 418 charts for these children aged 2 to 18. And some of the findings, I'm not going to go into a lot of details, but the age group of these children, some of the numbers are missing from my slides. I don't know why. Slides did not look like that initially. For some reason, there have been some changes before I get them back. But the most children who've been diagnosed with autism usually fall in our study between the ages of 0 and 5, as expected, followed by the next age group, which is 6 to 10, and then 11 to 15, and then, you know, smaller percentage get diagnosed this late, 16 to 18. Some of the and by the way, this was part of a paper we published. We looked at the other associated mental health condition with the autistic children. So many of these children, almost 80%, are diagnosed with ADHD. Many of you are familiar with that, hyperactivity, poor attention. Many of these children, up to 84%, have language delay. Many of them have intellectual disability. In our sample was more than 50%. And a lot of these children have behavior problems as expected, almost 1/3, anxiety, sleep problems, problems with enuresis or encopresis, and a very small percentage may suffer later on as adolescents, 16 to 18, are diagnosed from psychotic disorders like schizophrenia. Medical conditions associated with the autism spectrum disorder in our study showed that as the number of comorbidities or associated mental health conditions increase, there is an increase in demand, so medical services. So with the sample that we had, you know, about 30% has no associated diagnosis, about 35% had one associated diagnosis or comorbidity, about 30% had two more comorbidities, 10% had 3, 4, and then 5, so on. Medical conditions, these children suffered from, as I mentioned earlier, from medical conditions. These include about 18% variety of medical conditions, about 13% in our sample compared to the international figure, which is 16% suffered from seizures or epilepsy, 7% suffered from GI problems, bowel disease, about 9% suffered from immune disorders. And the impact of comorbidities on number of visits is significant. So as they have more comorbidities or associated disorders, their demand on healthcare system increases significantly. Now, last part I will talk about is the treatment. What do we do? And I'll talk about different aspects of the treatment. You know, behavioral, language, occupational therapy is still the golden standard. A lot of these children, regardless of what treatment they get, they still need speech and language treatment. And as it shows here, we use picture exchange, communication, what we call auditory integration. Frequently one-on-one is really, again, a standard to do the interventions with these young children. And it depends really on whether it's mild, moderate, or severe end of the spectrum. Occupational therapy to address, you know, the sensor integration issues, what we call the fine motor skills, how they use their fingers, and then behavioral management of self-stimulation behavior, repetitive ritualistic behavior, or even some of the self-injurious behavior. Now, something very important here with this intervention is early intervention is key. So if a child gets diagnosed early at age 2 or before age 2, receive these services, in a few years' time, they could look a lot different. At age 10, this intervention is going to have minimal impact. Their impact tends to be more intensive. So the ABA or applied behavior analysis is the only one that's been evidence-based, shows really significant improvement with this intervention. There is different programs like what we call Sunrise program. This part of this is called floor time, relationship development intervention, RDI, and rapid prompting method. A lot of this require one-on-one intervention. There is treatment education for the autistic children. Some of them are handicapped and they need other services like physical therapy, improving their skills, so forth, and depend on their needs. Regular follow-up is really important. focusing on other what we call associated or comorbidities, medical and psychiatric. So this is the behavior part, and non-medical, then we have the medication, and then we have some alternative treatments that I will talk about, like the dieting, which needs to be free of dairy products, essentially casein and gluten, which we see in cereal. Now, the medications usually target associated symptoms like anxiety, aggression, OCD, obsessive compulsive features, ADHD-like symptoms, hyperactivity and impulsivity, sleep problems, seizure disorders, mood changes, and repetitive behaviors. Medications for the core symptoms. Now, for the longest time, we were focusing on the behaviors and other associated symptoms. Now, the good news is we do have some symptoms that focus on what we call the core symptoms, main symptoms of autism spectrum disorder, which is the self-stimulation, repetitive behavior, ritualistic behavior, the poor social skills. One of these, or some of these medications include balovaptan and soramine, what we call the third stage of development have been completed. They're expected to hit the markets probably by now or sometime this year. Medications for some of the associated symptoms, like the repetitive behaviors, the aggression, self-injurious behavior. Some of these children could be very assaultive. So some of you who have these children with autism spectrum disorder recognize these medications: risperidone, aripiprazole. The two medications are approved for treatment of autism spectrum disorder. And then there's some of the ADHD type medications, Concerta, Vyvanse, and Strattera. The medications for ADHD are stimulants, non-stimulants, SSRIs, like antidepressants, anti-anxiety medications like escitalopram, sertraline, and those types are helpful for anxiety, OCD type symptoms. And then I mentioned just the two, the typical antipsychotic, risperidone and aripiprazole. Then we have melatonin, which is an herb that we frequently prescribe to these children. It helps sleep. And then there is medications for seizures. Alternative treatments includes diets, gluten and casein-free diet. Now, for very young children, if applied very early in life, can be helpful to a small percentage of these children. Sometimes it helps the hyperactivity. Sometimes it might help some of the minor or core symptoms of autism. The trick is to apply it early. Now, this is really a tough approach to apply. Why? Because gluten and casein dairy products are the main source of proteins, source of diet for many of these young children. Now, to give them alternative is not that easy, and it's not easy to apply. You deprive these children of really important sources of protein, fat, and vitamins that they need. So applying this is not easy. It could be very useful to some children. It requires, following this dietary regime for many years. When you apply it after age 10, it really has almost no benefit in my experience. Now, as you would imagine, the casein-free, so alternative dairy products like, the almond or gluten-free diet, which you need to exclude a lot of the cereals. Vitamins supplies, particularly B6, magnesium, B12. Some preparations like Super Nuthera have been prescribed. Yeast treatments, stem cell treatment, really has no strong evidence to show it's a good treatment for autism spectrum disorder. I mean, a lot of people do it. It's very expensive. It has not really shown any, there's no strong evidence to show it's really effective. Ozone therapy, not really very effective. There are some other interventions like secretine, which is a medication, intravenous use of immunoglobulins, steroids, antiviral, and chelation. Many of these interventions have been prescribed. None of them really shown very strong evidence to show it is a good treatment for autism spectrum disorder. I'm coming to an end of my talk. I had this is some of my publication. One of them is in Arabic about autism spectrum disorder, and I've contributed a chapter about medication management of autistic children in this book called Pediatric Neuropsychiatry, which is published by Springer Publication, along with my colleagues at Yale Charles Study Center, where I completed my training. This is my book about anxiety, which is in Arabic, and then about child protection in the Arab world. My book in Arabic about attention deficit disorder. This is the book about autism. It's a small book. I'm in the process of publishing a larger book within hopefully next year about autism spectrum disorder. It's going to be in Arabic language. This is the end of my talk. Thank you very much for listening. And if you need to reach me, I am on the social media, Twitter and other outlets, mainly Twitter. Almay Ahmed 2 is my Twitter account. You take goodbye now. And